on with Penn. I think Dr. Tanyi is fabulous.
Oh,
And I really felt like I really wanted to get the word out because a lot of people, I read a lot about this, and I know there are a lot of people who are suffering from different forms of cancer and aren't really seeking things out, and the doctors aren't always telling us. So I think it's really important that we become informed about it ourselves. So I set this up with Dr. Tanyi and the folks at Gildas Club to see if we could spread some information out here. Belinda in the back is another patient whom I just met for the first time today, but we've been corresponding via email.
Oh, you don't know each other?
No, we just met today.
Okay.
We correspond, there's a whole email network going on.
Oh my gosh.
So we trade secrets. So Dr. Tanyi?
Thank you very much. I'm a GYN oncologist and an assistant professor at the University of Pennsylvania. Sorry for this accent. I was born and grew up in Hungary, but hopefully you will understand my English, or my Hungarish actually. It's a special language what I developed over the years. So I tried to step by step I will talk about the immunotherapy trials at the University of Pennsylvania against ovarian cancer, what I'm the principal investigator. We have 2 trials what we closed in the past. I will present those results first, and after I will talk about the trials which are going on right now, and we have also planned to open new trials, so I will put just a couple of slides about them. So everything started many years ago, around 2000, 2001, when Dr. Kukos found that about 50% of ovarian cancers has tumor-infiltrating lymphocytes present in the parenchyma part of the cancer tissue, these little brown spots, and others don't. And he found that those particular patients who had T infiltration present in the parenchyma part of the cancer tissue, it's associated with a much better progression-free survival, longer overall survival, and a much better response for first-line chemotherapy. Since then, multiple other groups in Japan, in Canada, in the United States, Sloan Kettering and MD Anderson Cancer Center confirmed this phenomenon. And even a couple of my earlier work, like we see here, I evaluated 186 patients' tumor tissue. I found that the presence of CD3 and CD8 expressing cytotoxic T lymphocytes in the parenchymal part of the cancer tissue or in the ascites of the patients associated with a much better progression-free survival and overall survival, and somehow they respond much better for the first-line chemotherapy. So this is started this way, that we recognize that immune response and immune system has some form of effect on ovarian cancer and treatment outcome. One of the earliest application ever came from a Japanese study where a group of patients, as we see this line, received adoptive transfer of tumor-infiltrating lymphocyte, and the progression-free survival, at least short-term in this particular patient, was significantly better than those patients who never received such a treatment. So that was also exciting, but this was again a non-specific immune response short-term effect, so definitely needed lots of further work. But how does immune system can work against ovarian cancer? So I always love to say a couple of small examples for my patients, that how many times a person had chicken pox, and how many times, for example? Once. And what about you?
I don't remember having it.
Okay, I'm sure you had.
I probably did.
And what about this young gentleman? 2 times. It's almost impossible, because the first time he got immunized against by his body, and what happened, we all had chickenpox about 20, 30, 50 times over our life, but we had symptoms and full-blown disease once, because when first the chickenpox arrived in our body, we were like 2 years old or 1 year old, and the virus get into the varicella virus into the body, just a non-specific immune response responded for the virus, so they could grow. We get fever, we get the spots, our mothers were very nervous, and a couple of weeks later, when the non-specific immune response reached a little bit of effect, so we started to get better, the dendritic cells picked up those little viral particles, and this happens with bacteria, viruses, and lots of other foreign materials, and took these little viral particles and took to the working station of the immune system, the lymph nodes, where they presented these viral particles to the naive T cells which were not activated that time. So each single antigen presenting cells, we call them dendritic cells, but there are multiple types of them, presented one single antigen to the naive T cells. The T cells activated against that single antigen, which that time was a varicella or chickenpox antigen, and then started to multiply. Millions of T cells get out to the circulation, and we get better, and we went back to school that time. A year later, the next varicella came, but that time we had already had memory cells, T cells, specialized T cells, and as I'm standing here, I'm sure that I have millions of memory T cells against different type of viruses and bacteria. So whenever it comes back in our body again, we within 24 or 48 hours producing millions of specialized T cells which are really there and waiting for the stimulus which is presented by the antigen presenting cells. What's the problem with cancer? The cancer cells are our own cells, so it's my cells, which means that it can hide and can somehow get out from immune surveillance, because those particular tumor associated antigens are very weak antigens. A virus, a bacteria is a foreign antigen. It's strange for my body. It's coming from outside. But a cancer cell, which is created from my own cells, not from my ovaries because I miss those organs, but in what I try to create against this ovarian cancer, these antigens are very weak antigens. So I have to help to the human body, to the patient's body, to learn and recognize those antigens and do something against them. So what we do, we represent these antigens, and I will show step by step how we do this. And we take out these dendritic cells, we activate these dendritic cells and inject back to the patient's inguinal lymph nodes, and the patient starts to produce the T cells against those tumor-associated antigens. So right now, let me give you a little historical background. At the University of Pennsylvania, Dr. Kukos and I worked on 2 immunotherapy trials between 2008 and 2010. These were the UPCC 11807, I will present the data, and the UPCC 10808. The first trial was a dendritic cell vaccine trial, and the second an adoptive T cell trial. Based on the results, we developed 2 new trials, and here is Suraya, who is the chief nurse of this and one of the dendritic cell vaccine trial, which I have 2 persons here who received those particular treatment, and I would be very happy to if you share your feelings and memories about this trial. How did you feel? How was this? And the UPCC 19809, which is a dendritic cell vaccine trial, and UPCC 26810, which is an adoptive T cell trial, and also we have one more trial, a dendritic cell vaccine trial for patients with compassionate need. In these particular trials, we use whole tumor lysate antigens. And why we do this? Because the problem with ovarian cancer, that each single generation of cells are different. Even inside of the tumor, the cells are very, very different. The TCGA, the genomic analysis of ovarian cancer, just showed that even a single ovarian cancer cell has 60 different type of mutations. Now, why is it easier to target melanomas and lymphomas and leukemias? Because those are very similar. There is a originating cancer cells multiplying, and the cancer cells generation by generation stays the same. So in ovarian cancer, unfortunately, this is not the case. This is why they develop drug resistance, because the new daughter cells are different than the original cancer cells. So in this situation, we have very few antigens which is expressed in 30, 40, 60, 70% of the ovarian cancer cells, and this is why NYESO, and I will talk about them a little bit later, or mesothelin or alpha folate receptor. But in our trials, we use whole tumor lysate antigens. These whole tumor lysate express the whole array of tumor-associated antigens, millions of tumor-associated antigens in this particular patient tumor samples. And which is the most important, when I use the autologous whole tumor lysate from the patients, I create the vaccine which immunize the patient against those particular antigens which is the mostly expressed in the patients. So I individualize the treatment. So this was historically back 11807, and this was the first dendritic cell vaccine trial. Dr. Kukos was the sponsor and the PI, and at that time I was a fellow and helped to do this. So first step, we perform the surgery on the patients, unfortunately called like the autologous tumor tissue, and also the patients later underwent apheresis in order to collect the antigen presenting cells, which were further stimulated in the laboratory with the granulocyte monocyte stimulating factor and interleukin 4. And we lysed the tumor, autologous tumor tissue, and this lysis supernatant was loaded on the naive antigen presenting cells. They get activated, they pick the antigens, the tumor associated antigens, and we isolated actually that at the beginning company, this Northwest Biotherapeutic helped to do this. Today we do at the University of Pennsylvania in the vaccine producing facility. We isolated these activated dendritic cells, and these dendritic cells were injected back to the patient's inguinal lymph node under ultrasound guidance. So this was the original trial designs back in 2008-2010. After surgery, enrollment, apheresis, the patients underwent two preconditioning cyclophosphamide and bevacizumab. We use cyclophosphamide and bevacizumab because they have immunomodulatory characteristics. Bevacizumab decreasing the endothelial tumor barrier makes it more penetrable for cytotoxic T lymphocytes. Cyclophosphamide decreasing the activity and the concentration of CD25 regulatory T cells in the tissue microenvironment, because whenever we have a inflammatory reaction, first it's get a big bump, red bump here, and after it goes down, a regulatory T cells which shut down the immune reaction. So when I generate an immune reaction in the patient's body, I don't want it shut down by the regulatory T cells, so I have to do a couple of steps against them. After this preconditioning treatment, the patients underwent free dendritic cell vaccination in every 2-3 weeks. And those particular patients who have objective response and measurable disease could continue to the adoptive T cell trial at the time, the UPCC 10808, and those who didn't had the opportunity to continue maintenance vaccination. We changed this characteristic later. So we see here, that time 6 patients were enrolled. The average age of the patients were 58 years of age, and they received an average of prior 4.8 chemotherapy, different type of chemotherapies, and had a 2.6 prior recurrences. Radiologic evaluation, and we do the same with later trials. Radiologic evaluation of the patient's tumor burden was done at the time of enrollment and at the end of study visit. And the volume of each single tumor lesions were evaluated at the enrollment and at end of study visit. And as we see here, from the 6 patients who were enrolled, 2 patients has partial response. 2 patients have stable disease, it's very minimal volume, and 2 patients had progressive disease. Immune response was evaluated using interferon gamma ELISpot assay, and as we see here, the immune response in these particular patients correlated very well with the clinical outcome. At the end of study visit, we tried to do, some patients say no, but we tried to do a biopsy or order biopsy from the target lesions in order to perform an immunohistochemistry. And when we do this immunohistochemistry, we can evaluate the T infiltration. As you see, these little reddish purple spots are tumor infiltrating lymphocytes. And as you see here, unfortunately the non-responders patients had minimal or no T cell present. Meanwhile, those particular patients who responded had a lots of T cell presence in the cancer tissue. So particularly, we believe that based on the vaccination, the patients generated these T cells which already started to work and attack the patient's tumor samples. Here is one example. Here we see the vaccination PET CT, and this is a positive paraortic lymph nodes. It's unfortunately, you can see how easy to see the active cancer tissue, and this is the pre and the post vaccination. This is a short time period, about a 60 days difference, and we see how these particular lymph nodes started to shrink. It's a nice example. Okay, all right. So this is the outcome of the first trial, the 11807. 2 patients had partial response, 2 patients have stable disease, and 2 patients have progressive disease. We were very excited about this results that time because this patient population is already after multiple surgeries, multiple chemotherapies, and recurrences to reach a stable disease or even partial response without any major chemotherapy. This is definitely, we get excited. From these particular patients, 3 patients decided to continue and had the opportunity to continue to the UPCC 10808 adoptive T-cell transfer trial. And as we see here, that after apheresis, after very short lymphodepletion, the patient received the adoptive transfer of their own CD3 and CD28 co-stimulated cytotoxic T lymphocytes. So what we do after the dendritic cell vaccination, the patient undergoes a secondary apheresis. Here, in the first time, we took out dendritic cells, antigen-presenting cells. On the second time, we tried to take out the vaccine-primed active cytotoxic T lymphocytes in order to multiply them in laboratory and activate them with interleukin-2 and reinfuse to the patient. We have to do a short lymphodepletion because when we reinfuse the T cells, they need homing, they need lymph nodes. If somebody has an active immune system, as I'm standing here, and not a little bit depleted immune system, these T cells cannot home easily. So otherwise, they just get to the circulation, live a short day, a couple of days, and they get out, and the body just get rid of them. But if they can find the lymph node and homing and multiplying, we can reach the treatment effects much better. So from the 6 patients, 3 patients continued, and 1 patient had a complete response. Unfortunately, 1 patient had progressive disease, and 1 patient had a stable disease. So these were the first trials what we did in 2008 and 2010, and the summary was that dendritic cell vaccination and adoptive T cell transfer is a feasible, safe methodology with very, very few side effects, and we had 66% of clinical benefit rate, so we were very excited that time, and we decided to design the UPCC 19809 and 26810. So the next trial is the UPCC 19809, had a couple of new things what we built in with the hope to increase the effectivity. The patients underwent debulking surgery in order to collect the autologous tumor tissue, but this tumor tissue, first we lyse the tumor tissue and secondarily oxidize with hypochloric acid in order to increase the antigenicity and immunogenicity of the lysate, because these tumor-associated antigens are very weak antigens. Apheresis was done just as before, and the naive dendritic cells were collected and activated with granulocyte monocyte colon stimulating factor and interleukin-4 and loaded by this oxidized tumor lysate. This already we developed the facility at the University of Pennsylvania. We isolated the dendritic cells, and the activated dendritic cells were concentrated and injected back to the patient's inguinal lymph node under ultrasound guidance. So this is the UPCC 19809, which we have 2 patients here today. So after enrollment, apheresis and vaccine production, the patient underwent 5 dendritic cell vaccination. There were 3 cohorts which are closed, and cohort 4 and 5 are enrolling right now. Cohort 1, the patient received dendritic cell vaccination only, without bevacizumab, without cyclophosphamide, without anything. Cohort number 2, the patient received dendritic cell vaccination combined with bevacizumab. Cohort number 3, with dendritic cell vaccination combined with bevacizumab and cyclophosphamide. I can return to the original idea that why we use bevacizumab and cyclophosphamide, because they have immunomodulatory characteristics, as I mentioned, decreasing the anti-tumor barrier on one side and decreasing the regulatory T cell activity and concentration in the tissue microenvironment on the other side. Cohort number 4, we put, it sounds a little bit funny, aspirin on the side, because aspirin also a cyclooxygenase 2 inhibitor, decreasing prostaglandin and decreasing CD25 activity. And cohort number 5, we reorganized the bevacizumab and cyclophosphamide timing compared to the vaccination, because in the prior study we see a positive effect of it, and we intend to open cohort number 6 and 7 in the future. So whenever the patient finished this particular trial, they had the opportunity to undergo a secondary apheresis, in order to collect the vaccine prime cytotoxic T lymphocytes and had the opportunity to continue into adoptive T cell transfer, UPCC 26810. So in this particular free first cohort, we enrolled 25 patients, 5 patients in cohort 1, 10 patients in cohort 2, and 10 patients in cohort 3. The average age of the patients were 55 years of age, had an average of prior, if I remember, 4.6 prior chemotherapies and 2.3 prior recurrences. Based on racist criteria, after dendritic cell vaccination only, in cohort 1 and cohort 2, the clinical benefit rate was 53%, 1 patient had partial response, and 7 patients have stable disease from the 15 treated patients. From these 15 patients, 8 patients decided to continue to UPCC 26810 adoptive T cell transfer, and as we see here, 6 patients from the 8 treated patients developed and kept a stable disease, even 2 of them who had prior progressive disease. In cohort number 3, from the 10 treated patients, 8 patients had clinical benefit, 1 had partial response, and 7 had stable disease. So if I want to break down cohort by cohort, the clinical benefit rate was 40% with only dendritic cell vaccination in cohort number 1, 60 and 80% in cohort 2 and cohort 3. And I'm very excited to see cohort 4, what will be the outcome. Altogether, in cohort 1 and 2, 8 patients and 1 more patient in cohort 3, but possibly it's already changed because it's like 1.5 months old data. So, and we have 2 new finishers in UPCC 26810. So 9 patient data who continue to adoptive T cell transfer. 7 patients have stable disease from the 9 treated patients, so a clinical benefit rate is 77% here. These are the adverse events. Adverse events were evaluated using the common toxicity criteria, and there were 2 grade 3 toxicities, both of them were joint pain, and the most frequently seen toxicities were grade 1 fatigue and fever, which I have seen 4 times after dendritic cell vaccination. Do you remember any side effects?
Muscle pain.
Muscle pain here. And
But I didn't have
an
fever.
injection site or after infusion, when did you have this?
It was sort of ongoing for like the 2 weeks after.
Okay.
And then by the 3rd week it got a little better. But I have muscle pain anyway, so it's kind of accentuating what I already had.
Yeah, so increased a little bit.
Yeah.
And
I had some muscle pain. I had a spike in my blood pressure.
but that's it, bevacizumab.
Mhm.
Bevacizumab is famous to do that. It's 70% of the patients. So I try to look for like the usual dendritic cell vaccination side effect: fever, tiredness, a little bit of fatigue, a little bit of bump, redness, pain on the injection site. What about the pain? Any injection site pain?
Only, I've not at all up until the last injection. I did have some pain. Other than that, you know, it was fine.
I'm sorry for that.
Yeah, I always apologize.
I had none.
Okay. But this is my favorite. This is very early data, and what we see here is a progression-free survival curve of cohort 3, cohort 2, cohort 1, and the age and treatment matched population. These particular patients here completely matched in everything to the other 3 cohorts, only that they didn't receive any immunotherapy or any dendritic cell vaccination. You see the progression-free survival advantages. So immunotherapy is very, very early, very, very early. But after 500 days, after, as we see here, to have these progression-free survival advantage, it makes me very, very excited. These data needs to maturate, of course. I need to see over time what will happen exactly. But as an early outcome, it's very, very exciting. So here is one patient. We have long-term survival data from cohort 1 patients only because they were the first. These particular patients had 2 recurrences with a shortening progression-free survivals, 14 and 7 months respectively. The patient was enrolled into the first pilot study, 11807, continued after 19809, And as we see here, she has a 43 months of progression-free survival. She lives in New York right now. And we evaluated the immune response using the good old interferon gamma export assay. And as we see here, how her reaction, her T cells reaction increased when we stimulated these T cells from her blood with tumor-associated antigens, which is showing a great developing immune response. Immunotherapy is not like chemotherapy. I give the chemotherapy and it starts to work within 24 hours. It's immediately get to the cells and circulation. Immunotherapy needs time to develop an immune response. It takes weeks before we start to see any response. This other patient was enrolled in UPCC 1989 in August of 2010, and she had a stable disease at the beginning, but her CA125 started to elevate. She received bevacizumab, which temporarily decreased the CA125, which started to elevate again. This is what we see all the time. And she received the adoptive T cell transfer of her own CD3 and CD28 co-stimulated cytotoxic T lymphocytes, which caused the remission inversion. We evaluated her immune response multiple time point with interferon gamma export assay, and we can see as the immune response is increasing in her system. So, as a summary, I can say that these early results from dendritic cell vaccination and adoptive T cell, this is definitely a feasible, well-tolerated methodology. The side effect profile, even not close to the standard chemotherapy regimens. We had very exciting outcomes. The clinical benefit rate was 40, 60, 80% cohort 1, 2, and 3, and we are cohort 7, somewhere we close 6 or 7 patients, am I right? 7 patients. I'm very excited to see the outcome of this particular cohort 4 also. The clinical benefit rate altogether, the 3 cohort together, was 64%, but those particular 9 patients who continued the adoptive T cell transfer, we saw clinical benefit in 7 patients, which was 77%. So what are the future direction, and this makes me even more excited, because what I present here as early results, that was dreamed about 5-6 years ago. It took 2-3 years or 4 years in laboratory, and after 2 years regulatory work that the trial get accepted, and then finally we opened the trial, and then we worked 2 years with the trial. Now I have these results what I could present. But what I'm dreaming today, and I will show a couple of slides about it, it's not, this is, I hope that we can open in 2014, 2015, which completely new direction of immunotherapy, and this called the chimeric antigen receptor. And these particular chimeric antigen receptor, this was the first generation of this chimeric antigen receptor. This is already not used MOF19 because there are new chimeric antigen receptor right now at the University of Pennsylvania. What happens, we don't need the patient's cancer tissue anymore. We need the patient's T lymphocytes. So the patient undergoes apheresis, which is a boring time, 3 hours sitting next to a machine, blood is going out, coming back, and the machine is collecting these particular T cells. And in the laboratory, we can build in T cell receptors in these particular T cells. The question is, what these chimeric antigen receptor contain? What is that antigen? What this particular receptor will respond. And this is the biggest problem in ovarian cancer, that we don't have a single good tumor-associated antigens like in leukemias or melanomas, which is easy to target. So there are, right now, we have 3 target, folate alpha receptor, the mesothelin, and the NY-ESO, which is a definitely tumor-associated antigen. The NY-ESO's problem is about 30-35% of the patients express it. Alpha folate receptor, over 90% of the patients express. I mean, the cancer tissue overexpress it. It's great, but unfortunately, you can find a normal folate receptors in the brain, a little bit in the kidneys. There is another target, is the mesothelin, which is very overexpressed by ovarian cancer. But the problem, all the pleural, peritoneal, pericardial layers are expressed. So the patient has a little bit of fluid in the pleural cavity. Those lymphocytes immediately attack there, and I don't want them to do any work. But let me show an experiment. What it's it's about a 2 years old experiment from Dan Powell, and possibly I showed in the past. It shows how effective it is, but I will say what the problem with it. But I still believe this is the future. So if I take an immunosuppressed mice and inject with ovarian cancer, human ovarian cancer cell line, these cell lines can grow in the mice. And after a period of time, when the cancer is growing, we start to inject 3 different groups of mice. The first group just get some sterile saline, it's a control group. That's an injection, doing nothing. The second group get non-specific T cells, just simple T cells without any specific activation. And the third group get those chimeric antigen receptor genetically engineered T cells which are activated against a receptor, activated against a tumor-associated antigen which can be found in the tumor tissue. And it's of course, like everything in the laboratory, it's working beautifully. So we injected the mice in this time point, the tumor started to grow in all 3 groups. The treatment started here, and as we see here with the saline injected mice, with the non-specific T-cell injected mice, the tumor were growing, the luciferase is built into the tumor cells, so we clearly see under the skin these huge tumor nodules. But those particles who get the treatment, multiple chimeric antigen receptor genetically engineered T cells, responded very well. As we see, one mice has a little bit of leftover tumor. Now, already there are CAR trials existing in the University of Pennsylvania against leukemias, childhood leukemias, and also melanomas, and they have beautiful results. But chimeric antigen receptor genetically engineered T cells are dangerous, because when we push millions of active angry T cells in a human body, we generate like a septicemia in the patients. This is a similar reaction when the patient has sepsis, hypertension, tachycardia. Many patients get to the ICU in the first 24 hours. Interestingly, those patients are usually the better responders by the treatment, but this called this cytokine release syndrome is still a dangerous side effect of this particular treatment, and we don't know why and how it happens, because there is no correlation between the number of T cells and the cytokine release syndrome. So we already have 2 trials lined up. One of them is a mesothelin CAR, and the other is the antifolate CAR. With the antifolate CAR, I already hope that I can open in 2013, but regulatory issues and others postponed it, and I hope that these 2 CAR trials will open in 2014, and I can start treat patients, of course, with ICU background and all the preventive measures which needed for this treatment. So here the Dr. Kukos and Dr. Dan Powell, Dr. Kukos, who initiated this work at the University of Pennsylvania, he left and went to Lausanne, and Dr. Powell is still here. He's a PhD who works a lot on the chimeric antigen receptor, and here is my angels, my clinical team. We see Surya is here with us today, and Clara and Vijaya, the 2 regulatory persons, and Dina, Jessica, and Kathy help us in the clinical side of the work, and this is the Perelman Center. So, and these are the boys who are working in the vaccine producing facility. We have another Hungarian here, Gabor, not Hungarian, children, Andrew and Dan. They are great experts in vaccine production. So thank you very much. This was just a short summary, and I presented similar lectures in the past. As we have more and more data collecting this, we get step by step ahead. So 11807, the early trial, was a good start. 19809 give us more knowledge and more a little bit better outcome. But I'm very excited to see cohort 4 and cohort 5, and I wish that soon I can bring up the CAR trials and I can bring this up to first line, because I believe when we can bring up dendritic cell vaccination next to the first line treatment, debulking surgery, first chemo and immunotherapy together, I can effectively decrease the recurrence rate. Because immunotherapy, as I see, cannot melt away tumor nodules like this, like a soccer ball, but can very nicely control small disease and possibly can decrease the recurrence rate. And we are working hard on it that we get FDA approval to bring it up as first line. And then if I can bring it up to first line and I can do at least 50 to 100 patients and follow them for 5 years, and I can show that this decreased the recurrence rate, then we won. And this will be a standard of care sooner or later. But I will be a nice older guy at that time, and unfortunately everything in human research goes very slowly. So thank you very much for that attention, and I'm ready to answer any question comes up.
Are these trials being held anywhere else but in Penn?
These particular trials only at University of Pennsylvania. There are a couple of more immunotherapy trials here and there in the country. The problem with immunotherapy at this moment, like the first big screen TV, is very expensive. 5 years later it will be cheaper. But right now it's very expensive. We have to generate a lot of grant and financial support from...
A lot more expensive than chemotherapy and...
not all of them. Bevacizumab is more expensive. So a couple of chemotherapy more expensive than this, but like carbotaxol, the good old chemotherapies, they are much cheaper. But carbotaxol is not working on those patients who are in the trial because possibly already developed platinum resistance.
Do you have any hard copy paperwork for your presentation? You know, anything in...
I didn't bring, but
okay.
what I can do, I can send this over or print out and mail it. I'm very happy to do.
That would be...
Yeah.
I would like that if you could.
Do you anticipate that this vaccine will work for other types of cancer also?
There are trials which use dendritic cell vaccination on solid tumors because the CAR trial is mostly used on hematologic malignancies. Prostate cancer is ahead of us. It means that it's much more effective on prostate cancer so far than ovary. But again, when I see there are cancer types who are lots of like prostate and breast, but they don't kill the patients. Unfortunately, pancreas and ovary we have 24,000 new cases, and unfortunately we have 15,000 deaths a year. In breast we have 360,000 new cases, we have 10,000 deaths, less than ovary. Now in prostate, the dendritic cell vaccination works very well and a little bit better than, and there are more advanced trials and they are ahead of us. It's definitely there are publications about prostate and dendritic cell vaccination. And the other issue is to generate funding for a cancer type which has 20-30,000 cases, so small numbers, compared to skin, melanomas, high number, breast, and others which are high number. All the companies and grants want to support those type of diabetes. Half of the nation has diabetes or hypertension. It's much more easy to fund something, a more general disease. Ovarian cancer is a horrible killer, it's a horrible disease. But 25,000 new cases don't make lots of people excited who never faced or in the family nobody had ovarian cancer. So the funding is much more difficult. This is why possibly prostate again is much higher number prostate cancer. Because as we are getting older, we are getting there that almost all men has some, like 60% of the men has some form of prostate hyperplasia or a little bit of cancer. But those are very slow growing cancers, not killers.
I can't remember.
Bevacizumab, Avastin.
That's Avastin.
Avastin, yes. This is the only anti-angiogenic treatment which is approved by FDA. The only one.
It's approved by FDA.
Yeah, this is why we use this. I would be happy to use a much cheaper, easier available anti-angiogenic treatment, but this is which is approved. This is the only one.
And at this point,
certain cohorts get it and certain cohorts do not?
Right now, everybody gets it because the cohort number 1 didn't get it. They get only the
And they
cell
didn't do as
vaccination. Hmm?
And they didn't do as well.
No, they didn't do as well. So we saw a 40% clinical benefit rating only dendritic cell vaccination, and 60 and 80 as we put others. So we are using a combination treatment.
And what are the side effects from Avastin?
Avastin is usually hypertension, nose bleeding, muscle pain, upper and lower extremity pain, and there are a couple of very horrible side effects which is very rare, like bowel perforation. Yeah, it's about 1 to 5% of the patient's bowel perforation, which is very dangerous because it doesn't heal. Because Avastin stops the new vessel formation, so all the wound healing is slowed down. So everything like has positive and negative side. Yes.
Can you tell yet what the effect of the aspirin is doing in the?
So cyclooxygenase 2 inhibitor, we don't know yet. After I close so there are, again, we have laboratory outcomes, laboratory results, which, and animal models which show the beautiful result. And we already know that aspirin decreases the colorectal cancers. This is very well known epidemiologic study, and with these we put the aspirin on the side as a cyclo. This was the easiest, honestly, this was the easiest and cheapest addition to continue the trial, and we can put an extra things on the side and provide a care for the patients. Because there are beautiful checkpoint inhibitors which possibly very effective, but the companies for them, they don't give us out and they are very expensive. So we put this step, and so far it looks like it's working, in laboratory beautifully working, in epidemiologic studies working. In this trial, in cohort 4, we will see how well it works. But honestly, this is a phase 1 trial, so it should be a safety and feasibility. Then I see clinical efficacy, and I also avoid it because I'm eager and impatient.
And are there other ovarian immunotherapy trials going on in the country? Is there?
There is one GOG study which is using a dendritic cell vaccine against one single antigen. We have better outcomes. The GOG 252 and Dr. Kunle Odunsi in Buffalo, New York, developing NYESO-based treatment, but my concerns with that there is not high enough expression NYESO. 30-35% of patients express it, so it should be work there. But what about the other 65%? So, but they have some nice outcome in Buffalo, but we are a little bit ahead of them. These are what I clearly know. Yes.
How do your patients find you?
How did you find me?
I have a best story. I found you through my dog's vet.
Oh,
Yeah.
how could it happen? What did I do with the
It's
dogs?
really interesting. It's almost 4 years ago to the day that I was diagnosed with ovarian cancer. Monday would be 4 years. And I was in the hospital, and I had an appointment to take my dogs to the vet. And he called at home, and my husband said, "Oh, she's in the hospital, she has ovarian cancer." He said, "My wife is an ovarian cancer survivor. Give me her cell phone number, let me talk to her." So he called me in the hospital, and he said, "You have to watch this guy, his name is Kukos." And my vet graduated from University of Pennsylvania Veterinarian Hospital. His son was in med school, so he's on top of all this stuff. And I was like in this crazy, I have to get chemo right away, I was having complications, I said, "I can't deal with this right now." But I followed it. And I put a Google alert for Kukos' name, and anytime I saw something going on, I was following it, and I saw Dr. Randall at Pennsylvania Hospital. I followed up with him, and I said, "Am I a candidate for this?" Every time I'd say, "No, you have to have a tumor." I was on a trial that was working, and you don't have a tumor. And then that trial stopped working, so I went back in. I said, "Am I a candidate now?" He said, "Yes." So that's how I got in. So it's through my vet. So you never know.
How did you?
And it was through knowing a lot about Dr. Kukos, but I was originally with a different doctor, and I switched. But it was actually through one of the support groups early on who mentioned Dr. Kukos and that he's doing all this immunotherapy. So I kind of kept an ear out for that and heard about the vaccine. So I wanted to stay as
And you
close
came
as I
and
could.
didn't find Dr. Glucose.
Okay.
Better.
Not better, he's a
He was
great
just the
physician.
first name
great
associated with
physician.
it that was out in the news at that time too.
Yeah. He's a great physician.
But it's also like why I think it's important to do things like this, because the doctor that I was seeing did not suggest this to me. And, so it was really, it was me being out there and being aggressive, and I think patients have to do that more.
Last year I presented an SGO, Society of Gynecologists, and this year I get another presentation. So GYN oncologists around the world are there. This year will be Tampa, and last year was Los Angeles, yes. So I presented the cohort 1 and 2. Now we have cohort 3 next week. And it was very interesting. There was a anti-angiogenic presentation. I was with immunotherapy. There was a doctor presenting some laboratory work with metformin. And then they tested the audience. There were like 3,000 people sitting there. Tested the doctors and the audience, what they believe. And metformin and Avastin, everything did better than immunotherapy. It's new. It's not in the head yet that how immunotherapy can work again. And honestly, be honest, this is very early. This is very early. Very early, I had to turn away patients who I couldn't operate on because they're like carcinomatosis and I need cancer tissue for this. So whenever it's getting better and better and I don't need cancer tissue anymore, or we can take the cancer tissue at the first time, so when the technology developing and it's get more accepted, everything will be easier. And sometimes I'm Google search myself, and I get nice responses, and I get a couple of angry patients, and my heart is bleeding because I want to treat them, but my hands is tied. I have to follow protocols, and if I don't follow protocols, the DSMC, the FDA shut down the trials, and even those particular patients who are in cannot get more treatment. And to build this, and Surya is living with this every single day. To build this it's a decade, and even it's very early, and even there is no magic bullet yet. But it's better and better day by day, and I hope that one day I don't need to turn away a single patient, and everybody walks in, and we had a very nice new trial against cervical cancer. We had a site visit today, which will be. We know that HPV vaccination is out, but those are preventive vaccines. These are treatment vaccines. And we want to develop preventive vaccination against ovarian cancer. So the young girls will get preventive vaccination because cervical cancer was the #1 female cancer 50 years ago. And in Africa is still the #1 cancer. But the United States, whoever goes to the GYN and they get it early, it's not an enemy anymore. And right now we have altogether about 12,000 advanced cervical cancer a year. If we go back 50 years, it was 70,000. So it's going down. But ovarian cancer is a sneaky disease. It's billions of dollars were poured into the new treatment methods to find against ovarian cancer. There are molecular inhibitors, new chemotherapies, and over 30 years, from 36% 5-year survival, overall survival went up to 44%. 8%. It's minimal change compared what happened with cervical cancer. So there are still no magic bullet, but this is early results, hard work, and hope that if my belief is this treatment vaccination can come up as preventive vaccination after first-line treatment, and this will be much more effective.
We'll get there.
We'll get there, I hope so.
We will get
What would keep a patient from being able to enter the trial?
So to enter the trial, we get a lot of call, and we take the patient's data, all the clinical data and so on. If we have available tumor tissue from the patients, for example, as a reference, and I can operate, or some other doctor operate, and we have available cancer tissue, and also we have opening spots, then this is the way as patients get in. Now, of course, there are 10 times more patients
wants to come than us spots I have so far. Am I right?
Exactly. The
So-
line is pretty long.
Yes, and I'm not putting anything ahead or behind, so I enroll the patient as quickly as I can.
How is this decision made of what patients can, get in the trial and what can't? What's the criteria?
So what is the inclusion criteria? Over years of 18, recurrent ovarian cancer, available cancer tissue, visible minimum cancer, or a couple of no evidence of disease also can come, but we need available cancer tissue
How
from
do
the
you,
patient.
how does one get available cancer tissue?
This is the, we do debulking surgery to collect the cancer tissue.
Oh,
To optimally debulk the patient, take out as much cancer as possible. We need the cancer tissue because this is
Yeah.
what we use as a tumor associated.
so it's an
reaction.
operation to get the tissue?
Unfortunately,
Yeah.
Yes.
How-
And you also mentioned that you have to go through all the frontline treatments first.
yes, so that's, thank you. This is experimental treatment.
right.
I cannot put this treatment ahead of available standard treatment.
Yeah, I understand.
So the patient has to get, unfortunately, to use multiple prior chemotherapies before I can justify to FDA that the patient is
What does
eligible.
the operation entail, getting the cancer tissue?
It can be an open or laparoscopic, it depends on what's the patient
Okay.
history and what's the abdominal status. If the patient has already 5 surgeries and radiation of the abdomen, I will not go in with the laparoscope because everything's stuck together. But if there is one primary surgery, no intraperitoneal chemotherapy, so I expect that maybe it's a little bit open abdomen, not as many adhesions, like I can go laparoscopic or robotic surgery. It all depends on where is the lymph nodes. Lymph nodes next to the parotid chain, which is difficult to to approach. So many small factors decide each patient's an individual approach.
How many patients right now are currently in the program?
Right now we have in somewhere around 15 because there are cohort 4 patients, already cohort 5 opening, and we have adoptive T-cell transfer patients. And I remember from a prior lecture, you and your husband, am I right? Yes, I remember you, we met already somewhere.
Who?
You met,
You.
you met
Yes.
Me?
my brother.
Yes.
Kathy
Kathy
Burns'
Oh,
mother-in-law, right?
Yeah, husband.
Oh,
No,
husband.
no, that's a mother-in-law.
Yes,
That I remember.
remember. Yes,
But
I
she
remember.
raved about you
Mm.
in the program.
And it was very sad because she responded so well for the
She was
treatment.
on the trial for the
and
illness.
please correct me if I'm wrong.
was on the
She had a
trial.
hernia surgery.
Well, you know,
I-
as far as I know,
Yeah,
what
yeah,
it wasn't the ovarian cancer, it was,
yeah, exactly.
It wasn't the ovarian.
For the record, I think she was one of the patients that was on the trial the longest.
Right.
she was
She
doing, she was
She
doing
was
great.
the poster
She was
child,
She-
really.
doing fabulous.
She was
until
doing
had to have the
beautiful.
other surgery.
Yeah.
And what happened? Then she had.
She had a hernia
She had hernia
surgery.
surgery.
She had a hernia surgery and the wound reopened and mesh get infected. Am I right?
Yes.
And she had a huge dehiscence in. May I share this?
Yes, yes.
Okay, huge dehiscence with a huge inflammation, and that's caused she couldn't eat. Everything
She
started to
couldn't
scar
drink,
up, and it was very sad because I saw her somewhere in February. She did fantastic. She
Yes.
was talking that she wants this hernia surgery, and I said to her, please wait for the hernia surgery because I'm out of. I want to be there. I want to search your abdomen. I'm sorry to say that, but if we see cancer, we biopsy it. We see. And unfortunately I was somewhere, I wasn't present, and I don't say physicians' names. The surgery came with complications, the infection, wound opening, and when I saw her back in May, she was already 25 pounds lost with a huge open wound of the abdomen, inflamed with big bags on the side, and also, if I remember, she developed hydronephrosis. So, and I tried to do everything what I could, call other doctors to the front, like plastic surgeons and urologists, but she started to deteriorate.
Oh, we can all agree she thought you were the greatest.
Oh, thank you.
And she would have done anything you told her to do.
Oh, sorry.
It was the best thing.
Mm-hmm.